This conference will now be recorded.
This is a PCOS, that is polycystic ovary syndrome talk of 2017. This talk is very important because nice fertility guidelines, they did not mention very clearly about when you're going to give different ovulation induction regimes for this PCO patient or unovulating patients. Okay, so for that there is some clarity in this talk. Okay, and regarding, but this talk differs in some things from the guidelines also. So whenever there is a difference, remember well, so when the things are different in the talk and guidelines, you have to remember that you have to follow the guidelines and not the talk articles. Okay, that is the thing that you should remember first. And second thing is, this talk is very much important for the EMQ purpose. That means for unrelating patients, when you are confused regarding when to use clomiphene, when to use metformin, when to use LOD, and when to use gonadotropins. So this is the important thing that you should know, and the guidelines doesn't clarify itself in that. So for that, this talk is important. So we will start today's talk. So prevalence of PCO, it is around 10 to 15% worldwide. Actually, in this talk only, they have given different figures everywhere from 25 to 50% for 20%, 25%. So remember well that the first sentence is about prevalence of PCO is 10 to 15%, while afterwards they have given different figures. Now, what are the features or clinical sign symptoms of PCO? So one is menstrual cycle disturbances and features of hyperandrogenism like hirsutism, acne, and alopecia, and with associated fertility problems, obesity, and psychological issues. Also, 34% people have previously undiagnosed impaired glucose tolerance, and 9% are diabetic. Okay, so these are the figures from this talk. So clinical manifestation, signs, symptoms, and late sequelae. So sign symptoms are features of hyperandrogenism like hirsutism, acne, and alopecia, menstrual disturbances, infertility, and obesity. While late sequelae of PCO, it is type 2 DM or diabetes, dyslipidemia, hypertension, cardiovascular disease, and endometrial carcinoma. Now, diagnostic criteria for PCO, according to ISHRI 2018, that is recent criteria I have given, because still the talk mentions old criteria. So I have given you this new criteria. So here polycystic ovaries, that is either 20 or more follicles on TVS. Remember, it is on transvaginal ultrasound. So polycystic ovaries, that means more than 20 or more follicles, or increase ovarian volume more than 10 centimeter cube. And the follicles dimension is 2 to 9 millimeter. Remember well, oligovulation or anovulation, and clinical or biochemical signs of hyperandrogenism. So, any two
Excuse
of
me, ma'am. Isn't it 12 or more follicles? Is it 20 or 12? Sorry.
12 and more was the old criteria, Rotterdam criteria. Now, ISHRI 2018, this is a new criteria, okay? And they have
Okay.
included this now
Thank you.
20 follicles, okay? Because of increased sensitivity of transvaginal ultrasound, okay? Probe sensitivity. So now the follicles number is 20, okay? So this is a new, okay? So that's why I have mentioned this new criteria, okay?
Thank you.
Still talk mentions old criteria only, but according to new ISHRI, this is the criteria, okay? Now, what is the endocrinology of PCO? So it is high or normal androgen level, that means testosterone and androstenedione level, high or normal LH levels. So LH is elevated in 40%, and it usually occurs in slim women. Normal FSH, high or normal fasting insulin because insulin resistance, but it is not routinely measured. But insulin resistance is assessed by GTT. Okay, low or normal SHBG, that is sex hormone binding globulin, which results in elevated free androgen index. Low or normal estradiol, anti-Mullerian hormone, but now just 1 minute, please. Sorry. So this biochemical or endocrinological manifestations of PCO. So it is a low or normal level of estradiol. Anti-Mullerian hormone, they have not yet included in any criteria. Okay. And prolactin levels are usually normal or occasionally slightly elevated. Now, USG, it is a polycystic appearance of ovaries. So as I told you, it is 20 or more follicle per ovary or ovarian volume more than 10 centimeter cube. So according to ultrasound, polycystic ovary prevalence is 20 to 33%. So according to ultrasound criteria, polycystic ovary prevalence is around 20 to 33%. So here you can see in this picture. So first picture is of normal ovary. Okay. Second picture, and these both are transabdominal ultrasound. A and B are transabdominal ultrasound. First picture is of normal ovary. Second picture is of polycystic ovaries. Third picture you can see it is a transvaginal ultrasound, and this is a picture of polycystic ovary on transvaginal ultrasound. Well, similar picture you can see on but it is a transabdominal ultrasound. Here you can see follicle size is more. There are more follicles, but follicle size is more. So when it is the follicle size is more than 9 millimeter, then you should not call it as polycystic, but it is a multicystic ovary. And E is a MRI picture. Here you can see this one and this one. These two are ovaries, and here you can see these are the polycystic ovaries. So these are the ultrasound features of polycystic ovaries. Now, what are the ethnical variation and epidemiological variation? So PCOD is a worldwide problem, but expression and presentation, it varies worldwide. For example, this Mediterranean woman, they have a greater degree of hirsutism. South Asian women, they have higher prevalence and degrees of insulin resistance. Also, PCO known to run in families. Almost 50% of first degree female relatives, they are being affected, and also increased risk of metabolic problems in their male relatives. Okay, so this known to be run in families also, and ethnicity wise presentation varies. Now, metabolic abnormalities related to PCO, as you know, it is insulin resistance, central obesity, and dyslipidemia. And this is the major cause of higher risk of developing diabetes and cardiovascular disease. So it is also known as thrifty phenotype or genotype. What do you mean by that? Is uh, it is usually found in the South Asian woman. So these areas are usually affected by famine, drought, and all these things. So because of that, tendency to obesity. So there is increased tendency to weight gain with normal diet also. And why it is that? Because it is known to preserve the population by maintaining the fertility. So even in case of famine or these things, when because of this phenotype, they can maintain their body weight with low diet also, or low, and they can have this population moving. Okay, so that the population will be growing instead of that famine also. But if this phenotype will not be there, then if they don't get the proper diet, they will fall below the normal weight range. They will fall below the normal weight range, and then there will be decreased fertility. So preserve this. This is known as thrifty phenotype. Now both obese and non-obese women, they are more insulin resistant than age and weight matched women with normal ovaries. So PCO, whether it is a normal or obese, both are insulin resistant. Women with PCO, who are oligomenoric, so they are more likely to have insulin resistance than those who don't have any menstrual disturbances. Also, to know this insulin resistance, what you have to do is, it is preferred that you should do this 75 gram oral GTT. Basic thing that is you have to do is fasting insulin level, but it is difficult to measure and it is not routinely done. So what is recommended is 75 gram of oral GTT. It should be performed that the BMI is more than 30 in case of PCO. And in South Asian woman, it is it should be done when the BMI crosses more than 25, because they are known to have more insulin resistance. So with the 75 gram OGTT, what are the values? So frank diabetes, when the fasting is more than 7 and 2 hours is more than 11.1. As I told you previously also, the conversion factor here is 18, remember well. Okay. So for fasting, it is 126 according to our milligram per DL. and it comes around to 200. Okay, impaired glucose tolerance, it is known as when the fasting is less than 7, but when the post 2 hours OGTT value is between 7.8 to 11.1. And impaired fasting glycemia is when the fasting glucose is more than 6.1 but less than 7, while the 2 hours glucose values are normal, that is less than 7.8. So there are two types. One is impaired glucose tolerance, where the 75 hours 2 hours glucose values are deranged, and impaired fasting glycemia, where the only the fasting glucose levels are deranged. Now, when we come to the obesity for PCO, so here rather than BMI, it is the distribution of fat that is important, because android obesity is a more of a risk factor for these cardiovascular diseases. Because the visceral fat, it is metabolically active, and when it is increased, it results in increased rate of insulin resistance, type 2 diabetes, dyslipidemia, hypertension, and left ventricular enlargement. So it is the visceral fat that we should measure. And how we are going to measure this visceral fat is by waist circumference. So waist circumference, it has a more value in determining the cardiovascular risk factor, because it detects the abdominal visceral fat. So waist circumference, it should be ideally less than 80 centimeters. Okay, but when it crosses 87 centimeter, it carries a significant risk of all these metabolic abnormalities. And 10% reduction of body weight, it will cause 50% reduction in visceral fat. So body weight loss is more important, because it is more associated with loss of visceral fat. Now, how you are going to diagnose and treat PCOS in adolescent? So diagnosis of PCOS, it should not be made until 2 years after menarche, because up till that period, cycles are very irregular because of hormonal harmony is not started. Okay, all elements of Rotterdam's consensus are required. So when we say that for this criteria, we say that 2 out of 3. But for adolescent, all elements are required for diagnosis of PCO. Then you have to remember that for hyperandrogenism, we take one manifestation as acne. But this acne is more common in adolescent period, and acne cannot be a manifestation. It cannot be taken as a manifestation of hyperandrogenism always. So it is hirsutism will be a better marker in case of adolescent for hyperandrogenism. Also, it is important to exclude non-classical CAH, that is congenital adrenal hyperplasia, because where it is more common in those ethnicities, it is you have to see for that diagnosis also. Also, you have to remember that menstrual irregularities are very common in adolescent. Mostly 65% have unovulated cycles. So that also you should remember while diagnosing the PCOS in adults. So when the diagnosis of PCOS is not confirmed, careful follow-up is required, and the diagnosis is reconsidered if the symptoms persist. And now the new ISHRI recommends that when the diagnosis is in doubt, full evaluation after 8 years of menarche should be done for the diagnosis of PCO in adolescent. Now, how you're going to manage this hyperandrogenism? Remember that the PCO women, they do not become virilized. Okay, so that means the signs of hyperandrogenism will be there, but virilization will not be there. What do you mean by that? That means they will not develop deepening of voice, increased muscle mass, breast atrophy, or clitoromegaly. Okay, a total testosterone level, it will be rarely more than 5. Okay, so testosterone level should be less than 5. If it is more than 5 and rapid onset of hyperandrogenism, you should also rule out other causes like congenital adrenal hyperplasia or other adrenal or ovarian tumors. Okay, so when the testosterone levels are high, that is more than 5, you should evaluate her further to rule out any other causes, because in PCO rarely the testosterone level crosses 5. Hirsutism, it is characterized by terminal hair growth in a male pattern. That is chin, upper lip, chest, upper and lower back, upper and lower abdomen, upper arm, thighs, and buttocks. So here you have to use this score, that is modified Ferryman-Galloway score, that is used for the diagnosis of hirsutism. And management, you have to remember that drug therapy will usually require 6 to 9 months. or sometimes it takes longer also before this any improvement is visible. Physical treatment can be done up till that time, like electrolysis, waxing, or bleaching. Okay. Usually, you should remember that hair growth occurs in 3 cycles. So 6 to 9 months of regular treatment is required. In meantime, topical use of eflornithine can be used. First line drug for hirsutism is Dinet. Dinet means ethinyl estradiol plus ciprotran acetate. It can work as contraception also. Then spironolactone, drospirenone, finasteride, and flutamide. These are other drugs that are used for this hyperandrogenism. Now, how you're going to manage this menstrual problems for PCOS is cyclical hormone therapy is the mainstay of treatment for this menstrual irregularities. You have to induce the artificial withdrawal bleeds regularly to prevent any endometrial hyperplasia. And how it should be done? That it should shade the endometrium at least every 3 months. So at least every 3 months, you should give withdrawal bleeds if their cycles are very irregular. In this talk now, as I told you, there are so many discrepancies with GTG. So here what they have given is when the ET crosses, endometrial thickness crosses 10 mm, then you should go for endometrial biopsy. But GTG suggests that when this 7 mm is there, when endometrium crosses 7 mm, you should do endometrial biopsy to rule out any endometrial hyperplasia. So you should go with this 7 mm only. You should not remember this 10 mm. Also, to avoid this endometrial hyperplasia, you can use Mirena, that is levonorgestrone intrauterine system. Now, this is a major topic of this talk is how you are going to manage the infertility associated with PCO. So, PCO accounts for 80 to 90% of women with anovulatory infertility. The principle of management of anovulatory infertility are first to optimize the health and then induce unifollicular, regular unifollicular ovulation. So, first basic thing is folic acid should be taken at dose of 400 micrograms, and in obese patient it is 5 milligram. Okay, so folic acid supplementation, semen analysis before ovulation induction, and cost effective approach. Tubal patency is also appropriate in every woman before commencing ovulation induction, and this goes according to the NICE guideline. So this you should remember before any fertility question or any fertility MQ, that these are the sequence that you should go for any fertility investigation. That means you have to confirm that she is rubella immunized or she is rubella negative. Then folic acid should be given, semen analysis should be done, tubal patency should be done, and this topic is of PCO, but otherwise for ovulation, only progesterone is required on day 25. Okay, so these are the basic investigations for fertility. Now, regarding lifestyle modification, so even a moderate weight loss, that is 5 to 10% of body weight loss, it can be sufficient to restore fertility and improve metabolic parameters, that you should remember. Right diet for an individual, which one that is practical, sustainable, and compatible with her lifestyle. So this diet fad should not be allowed or encouraged, but it should be sustainable and practical. It is sensible to reduce glycemic load by lowering sugar content in favor of more complex carbohydrates. So complex carbohydrates should be there in the diet and avoid fatty foods. Refer to dietitian for a diet management. Physical activity is promoted. That means 30 minutes per day brisk walk to maintain health or maintain weight. But to lose weight or to sustain the weight loss, 60 to 90 minutes per day activity is advised. British Fertility Society guidelines, they suggest that treatment should not be done unless the BMI is less than 35. But the people who have more time, that means when the age is less than 37 years or normal ovarian reserve, BMI of 30 is preferable. That means BMI less than 30 is preferable before starting the treatment. Anyone with BMI more than 40, it should be referred for bariatric surgery. Okay, and when there are comorbidities like diabetes, then BMI cutoff for bariatric surgery is 35. Okay. Now, ovulation induction therapies. What are the basic ovulation induction therapies are? Clomiphene citrate, parenteral gonadotropins, and laparoscopic ovarian surgeries. So women with PCO, you know, they are at high risk of OHHS and multiple pregnancy. That's why ovulation induction therapy should be carefully monitored with serial ultrasounds. So these are the three mainstay of ovulation induction, that is CC, gonadotropins, and laparoscopic ovarian drilling. Now, how you're going to go with that? So first choice is always clomiphene. You have to commence it at the dose of 50 milligram, and you have to start it on day 2 to 5 and given for 5 days. It is necessary to exclude pregnancy and then induce withdrawal bleed with a short course of progesterone. So if the patient comes with amenorrhea, you have to exclude pregnancy, induce withdrawal bleed, and then start clomiphene. Also, if you give 50 milligram of clomiphene and she has not come for ovulation monitoring, that's follicular monitoring, and if the patient has not menstruated by 35 days and she is not pregnant, that means you have excluded the pregnancy, then you should give a progesterone induced withdrawal bleed, and then again you should start with CC. The starting dose of CC is 50 milligram per day. You have to see whether the ovulation is occurring or not, or increase it to 100 milligram. Now, in this talk, they are telling that dose of 150 or more, they do not appear to be benefit. But according to guidelines, you should go up to 150. So, you should give the dose 50, 100 and 150 till she ovulates. CC, it induces ovulation in approximately 70 to 85% of patients, and approximately 60 to 70% should be pregnant by 6 ovulatory cycles. So 6 ovulatory cycles. Now remember that CC should be given up to 6 ovulatory cycles when the patient is ovulating. Okay. Hypersecretion of LH, it is found in 40% of women with PCOS, and it is associated with reduced chance of conception and also increased risk of miscarriage because of adverse effect of LH on oocyte maturation. So this elevated LH concentration, they are usually found in slim women with PCOS. Also, clomiphene causes exaggeration of this hypersecretion of LH, and they have anti-estrogenic effect on endometrium and cervical mucus also. So sometimes in hypersecretion with LH, this clomiphene will not work. Again, the CC, when you are giving CC, the woman should be monitored with follicular study, and because there is 10% risk of multiple pregnancy. This is again, you should remember. So with clomiphene citrate, the risk of multiple pregnancy is around 10%. Women with unavulatory infertility who are resistant to anti-estrogen, that means who are resistant to clomiphene, may be prescribed either gonadotropin therapy or they can be treated with LOD, that is laparoscopic ovarian drilling. Now, what do you mean by clomiphene resistance and what do you mean by clomiphene failure? So, clomiphene resistance means failure to ovulate. So, when there is no ovulation with maximum dose of clomiphene, it is called as clomiphene resistance. While clomiphene failure is patient is ovulating and patient is failed to get pregnant. So that is clomiphene failures. So resistance means failure to ovulate, while failure means failure to conceive despite of having ovulation. So if the patient is clomiphene resistant, then you should
So,
go. Yes.
Dr. Mudra, if it is
Yeah.
so clomiphene resistant is like with 6 ovulatory cycles only, or it is like we have to wait till 6 ovulatory cycles? They're ovulating or not? How it is like?
Resistance means not ovulating. Not ovulating means what? With 50, she is not ovulated. That means you are going to increase till 100. So you are going to increase the dose by 100. Then if she is not again ovulated with 100 also, then you are going to increase the dose till 150. Okay. And if she is not ovulating despite of 150 also, then you are labeling her at clomiphene resistant. Okay. So clomiphene resistant, there is no need to wait that you should complete 6 cycles. Okay. Clomiphene failure means you have to wait till 6 cycles. That means patient is ovulating but she is not getting pregnant. That is clomiphene failure. So for clomiphene failure, you will be waiting for 6 cycles. But for clomiphene resistance, once you have to go on increasing the dose. If she is not ovulating at 150 also, that means she is clomiphene resistance, and then you can go for further treatment. Am I clear?
Yeah, sure. Yeah.
Okay. So now for whom you are going to prescribe this gonadotropin is, one is clomiphene resistant, then persistent hypersecretion of LH, or anti-estrogenic effect of this clomiphene on endometrium. So for this, because if you give gonadotropins, there is risk of hyperstimulation or overstimulation and multiple pregnancies. So what protocol the authors have advised in this talk is low dose take-up protocol. So daily starting dose, very minimal dose, that is 25 to 50 units of FSH or HMG, and it is increased only after 14 days if there is no response. And then by only half of the starting dose. That means if you have started with 50, you should increase the dose to 75. If you have started with 25, you have to increase to 37.5. Okay, and then increase the dose every 7 days. So this cycle takes very long. Okay, but what they have found out is with low dose type of protocol only, the unifollicular growth and chances of unifollicular growth will be there. Chances of hyperstimulation and multiplier pregnancy will be raised. Again, when you are giving this gonadotropin, you have to remember that whenever you are going to give the trigger, that is ovulation trigger, that is SCG. So if there are more than 2 follicles, more than 14 millimeter, then you should not give SCG to avoid OHHS and also multiple pregnancy. So when there are more than 2 follicles, more than 14 millimeter, you should not go for trigger also. So what they have found out with gonadotropins therapy, cumulative conception rates are 65 to 70%, while live birth rates are 55 to 60% after 6 months. If the conception has failed to occur after 6 ovulatory cycles in a woman younger than 25 or 12 ovulatory cycles in woman older than 25, it can be assumed that ovulation is unlikely to be cause of couple's infertility. Because patient is ovulating, still pregnancy is not occurring, that means she should go for IVF or assisted conception. Now this is only the talk, this thing, this is nothing. Now we have mentioned this point in the guideline. Remember that regarding gonadotherapy, gonadotropins, when to stop. Okay, so how many cycles to give of gonadotropin? So nothing has been mentioned in the guidelines, remember well. For clomiphene, they have mentioned 6, but for gonadotropins, they have not mentioned number of cycles. Now, what is the role of metformin or insulin sensitizing agents in ovulation induction? So what happens with metformin is it inhibits production of hepatic glucose, so decrease the insulin secretion and also enhance the peripheral uptake of insulin. So when the metformin it is added to woman with CC resistance. Now remember that here everywhere it is not, once the clomiphene failure is there is no thing that already because she is ovulating. That means the option remains here IVF only. Remember well, if the patient is ovulating with clomiphene and then now you have to think of another treatment. She has not become pregnant. Then if she is ovulating with clomiphene and other parameters are favorable, then you should go for IVF only. Then there is no role of gonadotropin, no role of metformin, no role of LOD also. But all these options comes with clomiphene resistant. That means she is not ovulating with highest dose of clomiphene also. So here the option comes of either metformin or gonadotropin or LOD. So gonadotropin we have seen where there is persistent hypersecretion of LH will be there. There you can go for this gonadotropin. Now metformin is basically for the obese woman. Remember that. So the metformin is added to CC with CC resistant. The clinical pregnancy rate is increased, but there is no improvement in live birth rate. Metformin has limited value. Yes, Dr. BJ, please don't quote these references of other books because they don't go with these references. Okay, Kamini Rao and all other whatever other ones. The thing which is not mentioned is guideline is not considered for your MRCOG. Remember well. However, it may be correct, but it is not there for your exam. Okay. So yes, we know that we should give for 3 cycles, we should give for 6 cycles, we should give for 12 cycles, but no. Whatever is mentioned in the guideline, you have to go with that for at least your exam. Okay. So for CC resistance, for obese woman, you have to go with metformin. For slim woman, you can go for gonadotropins or LOD. Now I will tell you where LOD is preferred and where gonadotropins are preferred. But here, obese woman, you should go for metformin in case of CC resistant. So for those women with PCOS and impaired glucose tolerance or type 2 diabetes, metformin has a better role combined with lifestyle modification. So metformin therapy is always combined with lifestyle modification. Remember well. But metformin is also used alone for the ovulation induction also in case of obese woman. So when this metformin is used alone, so when the patient cannot come for follicular monitoring, okay, obese patient cannot come for follicular monitoring, then instead of CC, you can give her metformin for the monofollicular ovulation. Now surgical ovulation induction, that means laparoscopic ovarian drilling. It is free of multiple pregnancy risk and OHHS, and it also does not require intensive ultrasound monitoring. So this LOD is useful therapy for unovulatory women with PCOS who fail to respond to CC and who persistently hypersecrete LH. They also need a laparoscopic assessment of their pelvis. So if they require any tubal patency, any endometriosis, so whatever reason they require laparoscopy, who live too far away from the clinic to be able to attend for intensive monitoring that is required for gonadotropin. So now remember, in case of CC resistant and hypersecretion of LH, when the patient is slim, okay, when the patient is slim and high basal LS concentration, she is for LOD. The patient who can attend for follicular monitoring, she can be a good candidate for gonadotropin. Okay, so this thing that you have to take into consideration while choosing either LOD or either gonadotropins. Now for LOD, number of diathermy points are 4 per ovary for 4 seconds each at 40 watts. So after this diathermy, you have to instill at least 500 to 1000 ml of isotonic solution into the pouch of Douglas. That will cool the ovaries. It will prevent the heat injury and also adhesion formations. Now what they have found out is the patients who are treated with LOD, they took a longer time to conceive, and also 50%, 54% they require additional medical ovulation induction therapy in the form of clomiphene. Now when you are doing IVF for the polycystic ovaries patient, so most of the time what happens is unexplained infertility. Sometimes they have the PCO ovary pattern. They don't have any symptoms of PCOS, but ovaries are looking like PCO. So there is risk that they will respond sensitively to the hormones and there increased risk of developing OHHS. So the care must be therefore taken in these patients. And here, if you use GnRH antagonist protocol, there is risk of it lowers the risk of OHHS and multiple pregnancies also. So this is regarding this PCO talk. So all controversial points I have avoided which goes against the GTG. I have not included in the talk because this talk contains so many controversial points which is given against the GTG. So please don't read those. There is no need of doing that and confusing yourself. Okay. So this is the first question. An amenorrheic woman with polycystic ovarian syndrome, she was given norethistron 20 milligram for 5 days to induce withdrawal bleed, and following withdrawal bleed, she was commenced on CC 50 milligram from day 2. She has come back saying that she has not had a period after 35 days. What will be your next step in her management?
C is the answer.
Yes, please type in your chat box. Yes, very good. So answer is here. C. You have to do a pregnancy test after 35 days. If it is negative, give her a withdrawal bleed and then start again CC. Okay, so answer is C here. Next question. What is the best predictor of cardiovascular risk in 37-year-old woman who has been diagnosed with polycystic ovarian syndrome? Yes, very good. It is E. So BMI is not a good indicator, but her waist circumference is the most powerful indicator for predicting the cardiovascular risk. So answer is E. So thank you today for attending this class. Tomorrow, I think there will be no talk discussion. We will meet on Saturday again. Okay. So bye for now.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.